Postpartum adaptation. We're dealing with the fourth trimester. Now, ordinarily, there's how many trimesters during pregnancy? Yes, but then there's another trimester, which is known as the fourth trimester. This is postpartum period. This is after delivery. All right. Now, Ricky, what is postpartum?
After you gave the baby. Right?
And how long is postpartum supposed to last?
I'll have to do it according to the book.
Is it up to 4 hours?
6 to 8 weeks according to the book.
According to the book, it's supposed to last 6 to 8 weeks after you delivered the placenta. I have a question for you. This extra weight that I'm carrying, can I say it's postpartum weight when my youngest is 14 years of age?
No.
But of course, right? I can. She's like, no. Now, the book does say the actual postpartum period is up to 8 weeks, but some people are actually saying it can last as long as 12 weeks. After that, the weight that you was carrying is not because of the child. That's something else, okay? All right, and we remember again that this time is called the fourth trimester. During this time, this is when the birthing parent's body slowly returns to how it was before she was pregnant. There is some emotional roller coaster that does take place, as well as lifestyle changes, and that can last much longer than the 12 weeks. Okay, and we'll talk about those. But now you have to understand. In addition to the emotional roller coasters and the lifestyle changes, some experts do believe that adjustments can last up to a year after birth. So postpartum, again, is not just about the body or the physiologic changes that occur with the body. It also includes the emotional changes and how the new parent is caring for the newborn, okay, or this new child. And also about them adjusting to this new role. Now, we must consider cultural competent care. Torres, please tell me, what does that mean when a nurse applies cultural competent care?
Well, cultural competent care is going to be like knowledge-based care for each individual culture pertaining to itself. So like, let's say, for example, before you see a client, if there's something that you may not understand about a culture, you might want to do a little bit of research, something so that way, like, for example, like, I know the Chinese, like, they're for the women, there's a certain way that you have to address them. You have to address the husband, not the woman.
Okay.
For Muslim, you have to have a female, has to speak to, or has to be with the female clients. Jews, with the food preferences. So stuff like that, those are just certain things that you have to know before you address your clients, your patients, to know how to make them feel like they're being taken care of in their best interest.
Their best interest. I love what you just said. Also, to piggyback and add to what you said, the first thing to apply cultural competent care, we learned this in first semester, we have to address any cultural biases that we may have. How do you address cultural biases, Brant? It's not in the book, by the way, but how do you address it?
By acknowledging that you have some biases about that culture, and first of all, either speak with the patient and be like help me understand why you have this belief or tradition, or
Be careful, you're treading on thin ice right now.
Well, not really saying why, saying I want to know about your culture better.
Okay.
You better, so.
Now let me ask you this. What does it mean to have a cultural bias?
That
I feel like you're explaining something else. And this can come up on NCLEX too. So I want to make sure we have the correct understanding. What does it mean to have cultural bias? Hurry up before Chella steals your shine.
she can take it.
She can take your shine. Nah, man. Chella.
So, my understanding, if you're biased, then you don't agree with something that they are doing, and you have to keep that shit.
Okay, yeah.
Like let's say, for instance, Bob Marley, he didn't have to die. He could have had a blood transfusion in that surgery. from his toe, which is what killed him.
Oh, really?
And
I thought it
you
was
didn't know
poison.
that? He had a wound on his toe, and
He's Rasta.
he refused a blood transfusion.
Oh, I didn't
Just
know
like
that.
Selena's family refused a blood transfusion, she could have been saved after she got shot. I could say, well, I don't agree with this, so I'm not gonna treat you. That's cultural bias.
That's cool. Now, Brand, what you were treading to is cultural ignorance. Like you don't know about the patient's culture, so you're going to educate. And one of the means you can educate yourself about the patient's culture is to ask them, please tell me more about your culture. I would like to learn more. Cultural bias now is like, I have a problem with culture Z. I can't stand people from culture Z. So just like what Chella said is, I have to acknowledge, you were starting off right, I have to acknowledge that I do have this bias. Okay? Sarita.
I just wanted, there's a difference between like culture bias and religious bias. And I feel like we talked so much just then that we like blurred the lines. Like, for example, I'm just gonna take what Chella was talking about. Like denying or refusing or accepting a blood transfusion is a religious issue, not a cultural issue, if that makes sense.
I understand. You're actually defining it or separating it more.
Yeah, because I think it's so
Because it's the same thing, whether it's culture or religious, the same aspect, the same concept.
Right. But I think yes, of course. But I think it's different to say that you're going to, like, it just needs to be like,
You're saying, hey, religion is like Jehovah's Witness and Catholic
correct.
and
Like Danny
Christianism.
mentioned about like the kosher with the Jews and stuff, that's religion, that's not.
And then the culture is like people who come from country X or African Americans or Hispanics or Asians, etc.
Yes, like I'm aware it's the same concept, but like you do still, when it comes down to treating a patient, you have to have a differentiation
Yeah, but
because
that bias also comes down to the fact that a lot of cultures, a lot of religions are culturally influenced.
Yeah.
yes.
So that's why that line
like
is blurred. But
So
that's
culture
why-
is like the umbrella term
Correct.
because then there's also when you break it down further, if you want to further subdivide it, there's also political bias.
Correct.
Then there's also what else? Like someone's lifestyle,
Yes,
etc. But the culture is the umbrella for everything.
Yeah, no, I'm well aware of that.
Culture in a culture.
No, I'm
Yeah.
completely
Yeah.
well aware of
Yeah.
that. I'm just saying that.
You don't want to. You
It
have
can't
a
be
problem with
intertwined.
interchange. Yes. Okay. All right. Now, given that you are aware of all this cultural biases and cultural awareness, ignorance, etc., when it comes to providing postpartum care, all right, Seti, tell me, how can the nurse respect a client's culture when caring for that patient and their families? When it comes to specifically providing cultural competent care specifically to postpartum.
It's hard to like specify, but whatever the cultural practices are in that realm, in the healthcare realm, you want to respect that.
Okay, very good.
You educate yourself on do's and don'ts in that culture and you respect it that way.
Okay, and I have a question for you, Litzy. How does culture even affect how we provide care to a client who's of a different culture from us, from you as a nurse?
It can affect it by like kind of as a nurse you won't understand if you're not by like the same culture. So like you just kind of will be like, well, I don't get it kind of type of mentality instead of trying to understand it per se.
Okay, so it affects what? You're on the right track. So basically, if you say, I don't get it, now how does that affect the care you're going to provide to the client? What does it affect? You're on the right track. I just want you to name it.
Patient-centered.
Well, it is about patient-centered care. You're right. But what does it affect? If I have a patient who comes from culture X, okay, and I'm like, dang, I don't get none of this. What does it affect?
Your report?
Huh?
Your report, your relationship with the patient?
Okay, your relationship, or how about how you communicate with the patient? Because if I could see Litzy right now. She have patients from culture Z, and patient come in, you know, she comes into the room, and then she's like, okay, I'll be back. I can see that's what Litzy. 1 second, please. I can see Litzy doing that. Tell me I'm lying. Tell me I'm lying. Tell me I'm lying. Litzy be like, 1 second, please. Okay. So it would affect how you communicate. You are right, Ricci. It can affect the rapport, because remember, for you to have a great patient outcome, especially between the nurse and the client, you have to establish rapport. If that client can't trust you as their nurse or their care provider, then that outcome might not be as well as we would like it to be, right? It also can affect roles and expectations. Danny hit the nail right on the head with this one, because, for example, if I am a female patient and I have a male client, if I don't know that this patient wants to be taken care of by a male patient, based on their cultural or religious belief, that's gonna impact care. You understand? So that's why it's important for us to learn about it. Danny was very good with that. The one thing I want you to know is that some cultures believe childbirth is actually just a woman's responsibility. Y'all know that?
Family.
Okay, what you mean it's a family?
It's a family.
You know it's a fact, it's not your culture. What you mean? Elaborate on that. What you mean by that, Danny?
It's a family, because especially nowadays, like we know all too well with everything politically, but it's no longer just seen as mom and dad. You can have individual fertilization from mom, dad. You have moms who don't have dad. You have moms with family that are helping to raise child. You have dads that are having full custody and they have to have help from family or whatever. Dad with stepmom, mom with stepdad. So there's so many different different routes that it can be. So it's no longer just mom and dad.
Right. Okay.
You have to include also the care for the children. So like siblings, step siblings, all of that is included.
Good, I like that. Now, let me tell you, with regards to the partners, please do not put your political or cultural beliefs as it relates to the partners. Understand, even though in the United States, the partners are expected to be involved in the patient care, they are not required, okay? We would like to see the partners involved, whoever the partners may be, but it's not required, because for whatever reason, partners may not be involved. And there's a plethora of reasons that we can go over with, but you can imagine why they can't be there. Okay, whether they're not in the picture, they might be out of the country, they might be, I don't know. Huh?
If they're in the picture, they still can't be expected, even if they're there.
Even, that's true. That is true, even if they are in the picture.
Parenting plan that they have both designed for the child.
That is true, and it could be culturally based too. Or it could be their own personal reasons too. There's a lot of reasons why the partner may or may not be involved, okay? The other thing too, as it relates to providing cultural competent care, touch. You gotta be careful with touch. In some cultures, it is okay for me to go ahead and touch the client on their arm, but in other cultures, if I even touch you like in the nail, it's on. It's gonna be trouble. Okay, so make sure you pay attention to that, because that's part of cultural competent care. And read the room. You understand? Read the room. If you can sense when the client is uncomfortable or they're not, they seem like they don't want to be there or whatever. Just read the room. Okay, pick up on your cues. The research has shown when the partner is involved in the care, it actually helps with the developmental growth of the child.
And so as advocates and nurses, if we can encourage that.
I like that word, encourage. Thank you for that word.
Yeah, strongly. Get up.
Now, but hold on. Sometimes, men can sometimes feel unwelcomed in the healthcare setting.
That's why I'm encouraging them to be a part of this.
Okay.
I'm welcoming them in.
You want to welcome them, make them feel nurtured, make them feel like their presence is important.
Slippery slope, though.
Oh, talk about that slippery slope real quick.
Because now you're pressuring somebody to do something they don't want to do. So that's why you gotta. Or
ooh, wait, you
I
said
know they don't want to do it.
Exactly.
but you're applying pressure where it's not warranted. If anybody does that, like
Make them feel welcome, the partner?
you can make them feel welcome, but there's ways to do that. You're not gonna pressure a father to do so, because then now you could possibly, like I said, it's a slippery slope. So if there's already like
Tension
there, all you just did was you just severed that line.
Okay, then how can that be avoided then? Because you're right, it could be a slippery slope.
Document on your chart, and if you see something, you document on your chart, and you put it in for referral, and you leave that be. You let them bring you into that situation.
Okay.
That's why it's like you said, the culture of competent care. You have to know your client or your patient prior to interjecting your biases on the situation.
This is why it goes back to what I've been stressing with y'all since first semester. Nursing process. Collect your data. Your data or your assessment will let you know if you are treading a slippery slope. Because if that partner who's supposed to be involved in the patient's care is uncomfortable and you could sense the tension, this is why I said read the room. Because it could be some other personal drama. If the room tells you that there's some dramatic and you could sense that the partner is uncomfortable, don't force it. The reproductive reset. Okay, now what happens to the body after the body has given birth? Okay, so during pregnancy, we already know that the body does change to support the baby's growth or fetal growth and development. Now, after birth, we know that the body works to return back to its normal size or pre-pregnancy state, we should say, right? And this usually involves changes that affect all body systems, whether it be respiratory, GI, GU, etc. All body systems are going to be involved in the changes to get back to normal, especially the reproductive system. Now, when it comes to postpartum care, you've got to know that first 24 hours is very, very crucial. The first 24 hours after care is very crucial. Melanie, can you tell me why would the first 24 hours after birth would be very crucial, or is a critical time period?
Patient can hemorrhage.
Hemorrhage, very good. What's another reason? The first 24 hours is very crucial.
Well, hemorrhage, it could be signs
broad.
of infection.
Okay.
Yeah, so
Okay.
for that.
All right. So, given that, what are you, as a great fantabulous nurse that you're going to be, what are you going to do, or especially during the first 24 hours? What is your care plan going to include? Assess what? Vital signs. Okay, what else? What are you assessing, Schmidt? Okay. I felt like he was he was ready for me. Like, I know she's gonna call me. Okay. Yeah, you're right. The fundus. What else, Ricky? Besides the vital signs and the fundus. Okay, what are you looking at for in the vagina?
Yeah.
Vaginal bleeding. You're also in addition to that, you're also going to make sure you assess the tone of the uterus, or uterine firmness rather. Okay. You're also assessing the overall general well-being of the client, which is very important. You're assessing for bowel movements or lack thereof. Pain level, of course, because the woman could be in pain. Uterine tenderness, perineal healing, so you're putting a pad to assess for bleeding, and lochia. I have no idea what that is. Rolando, what is it? Lochia? Okay, what is it? Okay, it's not just bleeding.
Because you have rubra.
Okay. Because it can come out in different colors, which we're going to talk about, especially after giving birth. Now, it's also important that you help the patient or the parent learn how to properly breastfeed, if that's their choice. And if they do choose to breastfeed, you want to make sure that they know the different positions with breastfeeding, and we'll talk about that later on. You're screening for a thing that can actually happen, and it's very common these days, for postpartum depression. Okay? Now, postpartum depression and anxiety. Who are we screening for postpartum depression?
The father.
He ain't lying though.
The dad sometimes gets the symptoms of
That's
pregnancy,
true.
right?
Yeah. Okay.
What is that
that called?
No, you only know that because we.
Exactly.
Been telling you that.
So quiet over there.
At least he learned something. Give him that to me. At least he learned something. He kept it. Postpartum depression for both the parent, the birthing parent, and the partner, whoever's involved. Okay, and you want to make sure it's important that you provide information as it relates to birth control, and we'll talk about birth control later in a little bit. Okay, now it's important for you to make sure you understand that breastfeeding does not guarantee protection from pregnancy. Breastfeeding does not guarantee protection from pregnancy, so ovulation could return at any time. So let's talk about the different changes. So the reproductive system does go through changes. For example, after birth, the reproductive organs go through major changes to go back to normal. So you have the menstrual cycle. If they're not breastfeeding, periods will, or the menstrual cycle will return within weeks. If not breastfeeding, and ovulation could happen before the first period. So that's why you want to make sure you use extra precaution. Use other means of protection. The uterus is going to be stretched greatly during pregnancy, but it's going to slowly shrink back after birth to pre-pregnancy size or the normal size. Also, you're going to note that the breast will enlarge to prepare for milk production, but they do not return fully to their original size like the uterus does. Okay, because again, if you're breastfeeding, it's going to do there's an issue of supply and demand. It's going to continue to get a little, larger in size, okay? There is the issue of uterine involution where, first of all, I forgot what that is. What is involution? Kaylee, you know what it is? Uterine involution.
When it returns to its normal size.
Okay, when the uterus returns back to its normal size, so you're gonna see that there's shrinkage, right? This happens through three main processes. Make sure you know these. The process includes muscle fibers contract, the enlarged muscle cells, they begin to shrink, and then the inner lining sheds and they regenerate. That's what happens when the uterine starts to shrink or you go through uterine involution. The size of the uterus is usually about 2.2 pounds right after birth or 1,000 grams. Okay? But after about a week, it shrinks down to about 1 pound, which is about 500 grams. Then at 6 weeks, that uterus will continue to shrink to about 50 grams, which is typically the normal pre-pregnancy weight, a dramatic decrease. Now, the other thing you have to make sure you are aware of is what happens with the fundus. What's going to happen with the fundus? Anybody? Tell me what happens with the fundus. Great.
It's going to descend.
Huh?
It's going to descend.
What you mean it's going to descend?
It's going to descend back to the, it's going to shrink actually.
Okay, make sure you are right, that you note the timing. Okay, so the fundus usually goes, which is usually at the top of the uterus right after birth. The first 12 hours is at the level of the belly button. You gotta know this, and then each day it's supposed to drop about 1 centimeter, which is about 1 finger breadth, meaning you just put 1 finger, hopefully it drops. By day 3, it should be down to about 2 to 3 finger breadths below the belly button. By day 10, you should not be able to feel the fundus. By day 10. Very, very, very important that you note this, because if it doesn't, what does that mean? Okay, this is why we are constantly monitoring a birthing parent as much as possible, because that first 24 hours is critical, okay? All right. Now, what Torres was alluding to earlier, the lochia, we gotta talk about that. You must know or what to expect when it comes to the lochial changes. So, you have your different colors, rubra, serosa, and alba, okay? Which is like, just think albino white, okay, or clear. All right? So by day 1 to 4, you expect for the vaginal discharge to be very red. So it's like bloody, there's mucus, you're gonna see there's gonna be tissue debris, okay? That's rubra that usually occurs by days 1 to 4. And then you have between days 3 and 10, it starts to get lighter. That's when you start to see, that's because there's a lot of leukocytes, RBCs, and serous fluids. But you're noticing that it gets lighter. After day 10 is when you should see that it becomes even lighter because again, the tissues are getting debrided, there's leukocytes, etc. Here's where the problem. If you go through rubra, serosa, alba like you're supposed to, and then go back to serosa after you have achieved alba, that's an emergency. Okay, so that's a problem. This is why you are making sure you see that's about 2 weeks, give or take. If the birthing parent went through all of this and then goes back to serosa, or especially goes back to rubra, let's go get checked out like yesteryear. All right. So make sure you're always keeping educating the parent even after discharge, because some patients they go home after about a day. Okay. Usually they stay typically about 24. If there's no contraindications, no problems, they'll stay about 24 hours. With regards to the local, before I move on, your assessment should note the characteristics of the vaginal discharge, and the characteristics not only is just the color, limited to just the color, but also the smell. What should it be smelling like?
Nothing.
Roses. Flashy.
Yeah, okay. Nothing is what we prefer, but if it's smelling like it's fleshy, that's normal. But if it's smelling like, whoa, wait, like you can't, you know what I mean? Like it's fishy, like it's foul, like you just want to step right out, we got a problem, okay? Because that could mean infection, like endometritis. And the other thing you're assessing for is after pains, because there are uterine cramps after birth. That means that the uterus is contracting so it could stop the bleeding. It's normal. These contractions help prevent hemorrhaging, and if the uterus does not contract well, it can lead to uterine atony. Does anybody know what uterine atony is? Yes, and that could lead to what again? Bleeding, hemorrhaging, okay? Heavy bleeding, all right? So clients who typically feel stronger after pains are those who had multiple pregnancies or in the AKA multi-parous. Those who are breastfeeding because of the release of the hormone oxytocin, they could feel the after pains, and oxytocin also helps with uterine contraction as well. Usually if they do complain of pains or these after pains, you just want to treat them with ibuprofen or maybe acetaminophen, as long as there's no contraindication. Okay, the reproductive system after vaginal birth, we have the cervix, which opens after the uterus, and that cervix typically after birth is going to be swollen. Okay, it can also be bruised, or it can also be partly open. That's what you'll notice, but with time, it should heal, okay? It begins to close right away, which inside the opening, and make sure you know the other name for inside the opening is the internal os, because I might put one or the other, and that internal os should close by when? Within 2 weeks, okay? With these questions, again, I need you to make sure you pay attention to the timing, all right? The outside opening, that is the external os, and that never looks the same again. Internal os, again, closes about 2 weeks. External os is just going to be, it'll never be the same again. Before pregnancy, the cervix is going to have a round opening, but after childbirth, it's going to look like a slit-like shape, okay? And by 6 weeks, that cervix usually returns to the normal size, but it won't go back to its original shape, all right? So make sure you pay attention to that. What happens with the vagina after birth? Of course, after birth is going to be swollen and stretched. The tissue is going to be thin, and it may look wider or gaping. In other words, there's a gap. Healing time, make sure you know it heals around 3 weeks. Swelling can decrease and tissue thickens, but about within 8 weeks is going to return to it close to its original size. May not be exact, but near close to its original size. Just make sure you know the hormones that are involved is estrogen, which helps the vagina to return to its normal state before pregnancy. Now, what are some common vaginal issues?
Localized dryness.
Dryness, what else?
Painful sex.
Painful sex, what's the other name for painful sex? Yeah, okay, what else can happen?
After birth, like when you're
Mhm.
sometimes
Dysuria.
the muscle tone isn't as strong, so then you have like incontinence.
Yes, you can have incontinence, very good. What can we do for the dryness? Okay, make sure it's water soluble. All right, real quick, the perineum. Know what happens with the perineum. This is between the area between the vagina and the anus, so that little area right there. It does stretch, and many clients do experience laceration, okay, or in the AKA tears. Okay, they might go through episiotomy. Now, I think you guys told me this some time ago. It's usually preferred that it tear naturally on its own, even though you might have jagged edges. Now, what are some of the risk factors for these clients experiencing vaginal tears?
First pregnancy.
First pregnancy. What else? A big old baby. Okay, LGA. In other words, large for gestational age. So you got a big baby. Another risk factor is going beyond the due date. Okay, like especially when it's been 2 weeks and you still didn't give no birth yet. That can also be increase the risk of vaginal tear. Just note that the healing time can be about 1 to 2 days, but if stitches were used, healing may take about 6 months, up to 6 months. Okay. Now, severe tears can extend down to the anus and cause some pain once you with normal activities such as walking or bowel movement. You're going to be very, very uncomfortable. And it also increases their risk of having hemorrhoids as well. So we want to encourage the use of pelvic floor muscles, or the other word is the Kegel exercise, to help strengthen and support the bladder, the uterus, the bowels, etc. And recovery again could take up to 6 months. The reality of what happens, I already talked about this. We just said this causes is dryness. You have the rugae, or the vagina goes back to normal within 3 weeks, and a lot of people, up to 89%, sustain lacerations. Okay? Now, systemic shifts, hemodynamic. The different body systems. Say it louder, please, Eddie.
Don't play with her.
Yes. Okay? Consider me trying to prepare y'all for next semester. After childbirth, just note that the heart and the blood system goes through major changes, which include the heart shifts, of course, slightly upward and left, and blood volume does increase. Your cardiac output also increases, right? This is during pregnancy. After pregnancy, what happens cardiac-wise? It goes back to normal position, and your cardiac output stays high for a few days, okay? So usually it could be up to anywhere less than a week for sure, all right? It returns to normal. It should return to normal within 8 weeks. Sometimes for some individuals, depending on how bad or the severity of the cardiac condition was, it can go up to 3 months like the book says. Now, blood volume wise, of course, the blood volume drops quickly after delivery, but after that, it'll return to normal within 4 weeks, all right? The average blood loss, please make sure you note this. The average blood loss is about 500 mLs if you're giving a vaginal birth.
Yep.
It doesn't matter anymore.
It doesn't?
It's 1,000, what was it? It's
1,000.
1,000.
Regardless?
It's 1,000 regardless.
That's what they're saying in the clinical city?
Yeah.
To consider hemorrhaging,
To be considered,
it's 1,000.
It's 1,000 across the board.
Oh, okay, for this book purposes, guys.
But she said go buy our book, but
Yeah.
they changed
No, definitely go buy the
policy
book,
in the
but I'm saying-
hospital.
I didn't know that.
Yeah, it's 1,000 mLs now. We no longer use estimated blood loss now. It's usually just.
I would imagine that.
It's usually just quantitative now.
Mhm.
What you mean it's usually just quantitative? Explain that.
So estimated and qualitative is basically they're kind of like estimated is like it looks like it's around, but the quantitative they weigh it depending.
Okay,
like,
so they're
on-
trying to go as exact as possible.
Yeah. So what they'll do is, let's say for example, if they have like the actual, the pad, like not the pad,
It's a bag.
the
It's a
bag
clear
that, yeah, all that,
measures
that
it.
measures it, and they'll actually like get the actual measurement of how much is.
The bag has measurements
It
on it and they
funnels
hold
to
it
a
up and
cone.
they.
It funnels to a cone and it's like an emesis bag. Picture an
Okay.
emesis bag, so it lays out all
That's
the way
neat.
on the
And
bed, so
yeah.
as she's taking everything out and all the blood is coming, she
Yeah.
scoops it into the thing and lifts it up, and it tells you exactly how much.
And if it's a C-section, they'll get the rags, like the
Yeah.
actual rag, and then they'll weigh it. They'll have they know how much
Oh, that's
they weigh.
cool.
So they'll weigh it to see how much is there, and then they'll multiply, they'll subtract by how many it's, like they do the math, they'll know how many rags were used.
What
They'll
drag
multi- Yeah, what each rag weighs, they'll subtract that by how much that weighs, and now they have a quantitative blood loss amount.
Got
Well,
you.
Longwood does it a little different.
How do they do it?
With C-sections, they have bags on the side,
Mm-hmm.
and they have the little suction thing. So every time, there's a gush of blood, they literally suck it up in the bag, or it falls to the side in the bag. It tells you how much the blood loss. It's like a machine that just tells you how much the blood is sucked from.
From the vagina.
Yeah.
Oh, that would be probably more accurate.
Because they don't weigh when they're in there, they don't weigh the rags. They just count the rags. That's it. They literally dispose the rags after, but they never weigh the rags at the very end.
But the concept is still the same. They don't go by the 500 vaginal birth or 1,000 C's.
No.
Because they're saying they don't do that at what tradition?
Well, from when I had a patient go over 500 or close to 500, like for them 500 was a concern.
Ooh. So each facility is different.
Yeah.
I mean, the concern, I mean, it's still, it doesn't mean they're not gonna monitor the patient.
Right.
It's like what they're considering, like now is considered like hemorrhage is 1,000 mLs, like, okay.
Regardless if it was vaginal or
If you got
C-section.
1,000 mLs, they're like, okay, there's bleeding going on. If it's like 500, like she said, it's still good practice that the nurses tell us that, like, they still say it's good practice, they're gonna monitor your patient, because there's a likelihood. However.
Right. And all of this is being done within the first 24 hours.
Yeah.
Okay.
And then, but like on the, like, if you go to Cleveland Clinic and all the nurses stations for like the labor and delivery, postpartum, all of that, they have it like on the boards where it states it's 1,000, and it's regardless if it's either or.
For textbook purposes, just know that the average blood loss, if it's vaginal, we're going with the 500 milliliters, and then if it's C-section, we're going with 1,000 milliliters. Again, it's going to change depending on the facility that you work in, okay? When you get to that point, all right? But
Question.
yes.
Make sure we're on the same page. I heard you said the cardiac output returns after 8 weeks.
Normal. What did I say? Cardiac output stays high for a few days, and it returns to normal within 6 to 8 weeks, sometimes up to 3 months. Does the book say so?
14 days.
Yeah.
For simplicity's sake, we'll go with what I just said, okay? Cardiac output remains high for the first few days, but can go, it could take up to, just know that it could take up to 3 months for it to go back to normal. Let's just keep it simple like that, all right? Good catch, Ricky. Oh, don't play with me with numbers. Y'all know since first semester, I've been very big on numbers, so don't play with me. And I will plan to be petty with my numbers, lab values. Okay, even though the blood volume does drop, hematocrit may stay the same, or it can increase a little bit. But a sudden drop in hematocrit may mean hemorrhaging. So you got to look at the timing. So in other words, what that means is you're comparing the baseline, and if it's okay, we Gucci. But all of a sudden it went from, I don't know, let's say 14, and then it went down to like 10. We're not playing with those numbers. Does that make sense? So pay attention to the timing, because I'm going to put some scenarios, pre-pregnancy, day 1, and day this, so whatnot. Pay attention to the lab values. You've been warned, okay? What else? So vital signs. Temperature, of course, can increase up to 100.4 degrees within the first 24 hours or 38 degrees Celsius. Usually that's caused by a little bit of mild dehydration. We rehydrate, give her something to drink, and it should be okay. And this is normal. The only intervention is just hydration. You ain't got to do much, long as it's below 38 degrees Celsius. Okay? Now, I did have to, because I know your book is interesting, all right? I did go online and look up some reputable sites. They do not even consider to do anything until the temperature is above 39 degrees Celsius. When it's according to the latest literature.
100.4?
No, it's more than 100.4. So that's what, 101, 102?
38.
Yeah. Once it's above 39, that's when intervention takes place. Okay? Because they usually,
39.8.
above 39 degrees. Just know that. I just want you to know that according to the latest literature, and this was 2024, because you know your book is interesting. You do not intervene, you start intervention with regards to the temperature elevation at 39 degrees. Because typically, remember, the body is going through some changes. And generally speaking, it can resolve on its own. With simply rehydrating, we should be Gucci, okay? What else? Now, the heart rate, of course, there is mild bradycardia, which is common for up to 2 weeks. And this happens because of cardiac output is now starting to slow down. Now, what's the problem is when you have tachycardia above 100, okay? That's not normal. If you have tachycardia or a heart rate above 100, this is when it can indicate bleeding. It can mean that it's dehydration, but it also can mean low blood volume as well. So again, we're going to collect further data. We're going to see when was the last hydration. Sometimes if you simply rehydrate, that can help resolve the tachycardia. But if that does not resolve with with simply rehydrating, either whether it be intravenous or oral rehydration, we are looking further now because bleeding or hemorrhaging is a danger sign. All right. So blood pressure, again, it might drop slightly for the first 2 days. And it should return to normal. Please fact check me, okay? It should return to normal within 2 weeks. That's what I kept, okay? I ain't see no.
Book says 16.
16 weeks.
16 weeks?
Yes.
So the 2 weeks going back to normal was specific for heart rate. Under pulse and blood pressure,
Cardiac output.
Where does it say?
468 on the bottom.
Second sentence.
Oh, within 14 days.
Yes. You see it?
Cardia for up to 2 weeks.
Yeah.
And then it goes into the tachycardia, the next paragraph, and then on the right, it says the blood pressure is within 16 weeks that it goes. It could take up to 16 weeks for it to go
There's 3 different
to normals. Heart rate, it's usually normal or usually low, and it's common for it to be low for the first 2 weeks. Okay?
So heart rate.
The heart rate. Okay? The blood pressure can drop slightly for 2 days and then come back to normal within weeks. And the blood pressure is the one that takes 16 weeks.
Okay.
All right.
Okay? We cool?
Yeah.
Okay. All right. As long as we cool, we good.
And then the cardiac output.
It does say cardiac output normally returns to levels within 14 days. But focus really on the blood pressure and the heart rate. Okay?
Blood pressure is
That's why the
16
cardiac
weeks.
output is different in the different paragraphs, because, I mean, the first one refers to in general.
In general.
And then the cardiac output when it's talking about blood pressure, because heart rate and blood pressure is cardiac output.
No, they are part of the,
That's why the
yeah.
numbers are different, because blood pressure is 16 weeks, okay, 3 months, and then heart rate.
Heart rate.
Few days to 2 weeks,
Mm-hmm.
which is why.
Yeah, I know it could be confusing. We're gonna just stick with those two. Okay? Yeah.
So heart rate, 2 weeks.
And I'm gonna try my best. I know I said I'm gonna be petty. I'm gonna try to be nice to y'all. I gotta see how I'm feeling that day when I make the exam. I'm gonna try. Yeah.
Give us a review for
This is your review.
next test.
This is your review. This is your review.
Next test.
Blood pressure. Okay. What does high blood pressure indicate?
Preeclampsia.
Okay, postpartum preeclampsia. What does that basically mean?
Preeclampsia?
Mm-hmm.
Page 489, it says if the BP is higher than 140/90.
We gonna see 620 also says 140/90 should be obtained on 2 occasions, 4 to 6 hours apart, to be diagnostic of preeclampsia.
Okay. High blood pressure plus headache. That's what you need to be determined that you have postpartum, that it could indicate postpartum preeclampsia. You need to have at least both of those to start now investigating for that, okay? Now, when you have low blood pressure, what is that? What could that indicate? Infection, bleeding or infection. Low blood pressure could indicate bleeding or infection. Okay, I just need you to know that. Yes, Torres.
So that's one of the things that we were talking about last week, and I just wanted to confirm with you. So going to the baby really quick with that, the opposite. If the baby's, I guess, pulse or heart rate is super high, that usually indicates mother infection or mother.
Ooh, I have to go back to that. I don't remember that one. I have to go. I gotta go look that one up.
Because that was something that came up. Like there was multiple patients that have had that.
Where the baby's heart rate was more elevated than normal.
And she keeps reiterating that. So I just wanted to double check with you.
Mom has a temperature.
Yeah, she was like, if babies, they were like, baby's heart rate usually is correlated.
It is in the book.
To mom's temperature.
Yes.
Yes,
The baby
yes, it
can't
is.
sweat,
Yeah, they can't. Yeah,
Okay.
I believe so. But we're gonna confirm and validate whether with the book.
That's what Ron Jones
Yeah, it's, and I remember, I just can't remember exactly what it is. I don't want to lie to you, but yes, it, okay.
Thank you.
You're welcome, even though I didn't validate it yet, but we're gonna get there. Okay. High blood pressure, again, postpartum preeclampsia. Low blood pressure could indicate hemorrhaging or infection, okay? Now, this is why vital signs is very, very important. Blood clot, very important. After birth, the blood clot is likely to occur. Why? Because, of course, with pregnancy, it does increase clotting factors. Blood moves slower in the legs. There's blood vessels that may be damaged. And, of course, the patient may be less active because, you know, she just went through a traumatic event, okay? So that's why. This is why they are at increased risk for DVT. And we want to minimize those risk factors, okay? They could, in addition to being at risk for DVT, what else could this client be at risk for?
Which one?
In addition to having a risk factor for DVT, what else could this client be at risk for?
Embolism.
True. I want to say that Brent said it too.
Here you go. Okay, Brad didn't say it out loud. Okay, I want it for you to be louder. Okay? Okay, very good. So you could be at risk for DVT and PE, okay? Clotting risk remains high, according to the book, as much as 3 weeks after birth. As much as 3 weeks. So you ain't out the woods. Just because 24 hours you were Gucci, you still need to be not closely monitored, but the mom should be educated for the signs and symptoms of DVT. This is why you're educating a lot, because especially it's going to be part of your discharge instruction, especially if mom was discharged, 24 hours after delivery, okay? What else? So the risk factors for blood clots: history of blood clots, cesarean birth, multiple babies, obesity, preeclampsia, infection, anemia. All of that could likely increase the risk for blood clots. You're also going to be noting the blood cells. Now, don't play with me on the blood cell counts, especially white blood cell. What did we say was the normal?
20.
They can go.
Okay, what's the normal for the average general healthy? 5 to 10. But for the mom who just delivered, it can go as high up to what?
20.
20. I did a little research. There are some other OB books, but the latest literature they're saying it can even go up to as high as 30.
Yeah.
Yes, and they won't intervene. That's cray. I know, right? Yeah, but it has to for how long though?
For a week.
For about a week or less. 46, not 46 weeks. Whoa! You know, I might put that on the test too. You know? Okay? 4 to 6 days is when it stays high. So make sure, again, you're noting the timing. I might say day 1 and I might say day 6. This is what it is. What's your intervention? Okay? Now, you got to know that, again, if it's up to 20K, all we doing is what? Monitoring. Okay? Now, after 20K, we do have to make sure we bring that to the attention of the physician so that they can intervene immediately. Okay? But just make sure you know that high elevated white blood cells right after birth does not automatically mean that the client has an infection. Okay? Just make sure you know that. Moving forward. All right, boom. Multi-system recovery. Real quick, of course, we're going to go into the GU system. During pregnancy, the kidneys are working harder. The bladder and the ureters are stretching. But after birth, the kidney functions return to normal within 6 weeks, and the bladder slowly returns. This is why it's very important, especially if you want that bladder to be toned, well-toned. We do some Kegel exercise, okay? Some of the problems that they may have, some reasons why people have trouble urinating is because they may not feel the urge to urinate. They could have trouble emptying their bladder. And sometimes that trouble could be as a result of certain medications like an epidural, especially. Okay, that's why, or even oxytocin use. Okay.
No sense.
Oxytocin could be a reason why she has trouble urinating, okay? Also, swelling and bruising could be another reason, or a large baby, or even C-section, or episiotomy is another one. If you had episiotomies are so uncomfortable, by the way, okay? Okay? Or if they even had used an instrument like those vacuums, for example. All right. Make sure you know that after birth, the body does get rid of extra fluid from pregnancy, and it should reach a urine output about 3,000 milliliters per day, usually for the first 2 weeks, and that's normal. GI-wise, after birth, the bowel tone does decrease, leading to constipation, okay, but it's a common issue. Reason being why they have constipation, maybe it's because of the pain medications that they're using. Maybe it could be because of the surgical intervention, like the C-section, low fiber intake, low fluid intake. So you know your education doesn't help with,
Lack of mobility.
Lack of mobility is another reason. So we know we're educating to get them up and moving as soon as feasibly possible. Long as it's not a contraindication, we want the mom moving as soon as possible to help with that, okay? So we're telling her what to eat, like high fiber foods, and get up and moving. The other issue that you can see, especially it falls on the GI too, is, you ever heard of this? I can't pronounce it right, and don't judge me, okay? Diastasis recti.
Diastasis.
What is that?
That's what the abdomen.
What about the abdomen? Everybody got an abdomen. Well, they should.
Your abdominal, whatever is separated.
The abdominal muscles, you are right. What happens to the abdominal muscles? They separate. It also happens because the uterus is stretched, has stretched also the abdomen as well. And that's how they end up having the separation of the abdominal muscles. So if we do exercise, or you encourage the client to exercise, it can help. But it is going to cause future problems. It is going to cause problems with future pregnancies as well. Okay, just if they do certain exercises, it should help. The skin does change, you know, especially with the GI tract, the staying on GI system. The darkened, that linea negra that they had during pregnancy should fade away. Hair loss is common around 3 months postpartum. Whoop-de-doo. And hair usually regrows within 6 to 15 months. Now, they say at this point, stretch marks should fade, but they're not going to disappear. They may or may not disappear. Yeah, it is what it is. Some people actually, too, experience night sweats, too. Respiratory, I know it's not on here, real quick. After birth, breathing returns back to normal, so they can start breathing within 16 to 24 breaths per minute. Diaphragm starts to return to normal position, and shortness of breath should be improving, all right? And of course, the lung function will return to normal within 1 to 3 weeks. Endocrine system, after the placenta is delivered, the estrogen levels does drop within 2 weeks and progesterone levels should drop within 48 hours. And also that HCG that we use to tell you, could be used to tell you maybe you're pregnant, that should be dropping, okay? Should be dropping. Unless if not, then if it hasn't dropped, then we do have some issues. We might consider a tumor or something like that, okay?
Yes.
Breastfeeding hormones, okay? If you're not breastfeeding, prolactin will drop within 2 weeks. Ovulation should return sooner, but if you are breastfeeding, prolactin will stay high and ovulation will be suppressed, all right? The menstrual cycle may not return for up to 6 months for some women, okay? But it's important to know that ovulation timing is gonna be unpredictable, so you can't rely on that, especially if you're not trying to get pregnant, okay? And again, I said this before, breastfeeding is not a guarantee that you will not get pregnant. It's not a guaranteed birth control method, all right? Okay, so that is that. Moving forward, when it comes to the physiologic adaptation, but if you're gaining too much weight during pregnancy, you want to keep that extra weight at bay, especially after birth, because that extra weight can increase the risk of long-term obesity. In other words, it's going to be hard to lose that weight. What else? With regards to sexuality, the sexual health, postpartum changes does affect the mood. It does affect relationships. It can affect, have an impact on body image and sexual function. So some of the common concerns as it relates to sexuality or sexual health is a low sex drive because, the patient might feel tired, right? Pain during sex, which we talked about, which is due to dryness. They may have difficulty reaching an orgasm and they may experience fatigue, insomnia. Partners, be patient. Be patient. Be patient. The other thing as it relates to sexuality, you know that people tend, instead of going to healthcare providers, who are they turning to for friends and family? They're getting advice from friends and family. While it's not all bad, but you might be misinformed as well. Okay, so it is important that nurses do start that conversation as appropriate. Okay, again, as you read the room, start the conversation, normalize concern, and of course, offer guidance and reassurance. As it relates to lactation, okay, the milk production, again, I said it earlier, there's an issue of supply and demand. Lactation will increase milk production, but milk usually come within 5 days after birth, okay? There is the issue of engorgement, and again, what is engorgement? I forgot what that is.
So swelling because of the milk.
Yeah, okay? And that usually occurs within 3 days after birth, okay? So it becomes very hard, it's tender, it's very full. And some of the reasons why you experience engorgement is because maybe there's delayed breastfeeding, you're taking too long between feedings, poor latching, or you're not feeding as much frequently as you should, all right? The best way to help relieve breast engorgement is feeding every 2 hours or on a schedule around the clock. You can either pump or you can use a hand to express the milk as much as possible. Warm compress could also help with that. Cold compress too. Massage the breast. Make the baby feed. Okay, so those things should help. Oh, and then did I miss anything? Oh, ovulation. Again, I already talked about it. The hormonal changes that you will know is the estrogen is dropping sharply and progesterone drops within 48 hours. Again, prolactin stays high. Now, the opposite, high blood pressure. Remember, it has to be high blood pressure plus what? Plus a head. About that. I already talked about sexuality, the thing with attachment. When it comes to attachment, what you're trying to do, especially right after birth, is encourage that skin-to-skin contact, which allows for bonding, or the other name is kangaroo. They have the oxytocin release, which you'll notice, and you want to make sure you look at the data or the clues or cues rather that tells you how the baby and the mom are bonding. The sooner you get mom and baby to bond, the better. But what are some clinical reasons that can deter this from happening?
Baby's blue.
Huh?
Baby has to go to the NICU.
Baby may have to go to the big NICU or
Has to go to surgery.
postpartum issues. Maybe the mom has issues herself we have to address. Okay? Because this, if we're thinking about Maslow's hierarchy of needs, this means that love and belonging. But if, again, there's unmet basic needs that are not met, like physiologic needs, like for example, the vital signs, she's showing signs of preeclampsia or eclampsia, etc., we would address that responsiveness later on when it's safe. Okay? What else? Now, we already talked about a little bit of culture considerations. We said earlier, we got to be respectful. We got to be open-minded. We got to make sure we are not judging, even though we may have our own feelings about people from a particular culture, religion, or political view. We are not judging them. We are here to just take care of the client, okay? And we should have the willingness to learn, like Brant said earlier, okay? It is very important that we as nurses are culturally competent because remember we said postpartum is a very vulnerable time for this individual. Especially the first 24 hours. This individual is very, very vulnerable. So we're putting all our biases to the side. And about 60% of maternal death usually happen right after birth. That's very significant. And a lot of it has to do with lack of cultural awareness. We'll put it that way. Sometimes there's other reasons involved as to why that happens too, but we don't need to get into that. Y'all should already know. Okay? In your book, it does say in many cultures, rest after childbirth is very, very important. They gave the example of the Latin American culture, whereas, I think it's on page 475.
I know the Japanese disappeared. After they give birth, like they stay home. Like they do not go out.
Yeah, they don't go out.
Like you will not see a newborn Japanese baby out like in about.
Yep.
They like it's part of their culture where like a family will
Yes.
do everything for them.
Black people.
Yeah. We know that the different cultures mentioned in your book, they say like the Latin Americans, they have a 40-day rest period. Like yes. And please, I don't want to butcher it. How is it pronounced? Quarantena.
Quarantine?
It almost sounds like quarantine for real, right?
Quarantine, bro.
Oh, because I thought it was 40. 40.
40-day quarantine.
Okay, what happens during the quarantena is that the parent stays home and they rest.
For my quarantena, I couldn't do nothing. I couldn't go out in the cold. I had to cover my ears, cover any hole in my body. I was eating soups, drinking like warm stuff.
The whole 40 days?
I wasn't cleaning, I wasn't cooking, I wasn't.
Thank you. The yin yang, okay. You already know. So if you have, and y'all knew this from first semester, if you have a hot illness, they give you a cold treatment, etc. Okay. Again, you mentioned some of the practices. You already mentioned them: wearing warm clothes, staying indoors, eating warm foods, like the soup she's talking about. Avoiding cold foods like fruits and vegetables, etc. Okay? And it's important for us to be cognizant or even aware, because if we're going to be the home health nurse, we want to be very educated so we do not deter or mess up the care. Because if you go in there and be like, what you doing? Or why are you doing this? It's going to be a whole nother drama. In addition to what we just mentioned here, what's another reason? I know you mentioned some. What's another reason why, or what have you seen or learned or known to happen with certain cultures when they lack cultural competent care, when there's a lack of cultural awareness? What do you think?
Upon who? Like the nurse with the client?
The nurse with the client. When the nurse lacks cultural competent care.
They get agitated.
Huh?
Agitation.
What you mean?
Like, they get frustrated really easily because things aren't going like as they planned.
They get frustrated. The nurse could get frustrated, or you talking about the client getting frustrated? Okay, the client getting frustrated, or anyone involved in the client's care could get frustrated because care is not being taken done properly, what else could potentially happen?
Stop seeking care.
Huh?
Stop seeking care.
Elaborate.
Well, if they're not being treated how they expected to be treated, they won't seek care.
Okay. All right, but then what about if you're in a clinical setting, you're in a hospital setting, what could happen?
No,
Huh?
they just
Before we get to the
they
lawsuit.
just start to refuse the care from that person trying to provide it.
Okay.
So, like either like they won't take meds if it comes from that person.
Okay.
A lot of times they just end up firing that nurse and ask for a new nurse.
Okay. What else could happen? Chella?
The family will bring in their own stuff, like their own medications, their own foods.
Okay. And if they're not knowledgeable, that can also impact care. What's another grave thing that could also happen when the nurse is either being culturally ignorant, chooses to be culturally ignorant? What else could also happen?
Like it makes the patient question their decisions.
That could happen, yeah.
You're looking for something specific.
I am. I'm looking for something else. I'm looking for something else.
Do they just shut down altogether? Like,
what about care in general? How does that impact care in general?
Well, they don't trust the nurse anymore.
Okay, we got the trusting issue, but what happens to the patient? Can anything? Let me ask this: what can anything happen physiologically to the client once that nurse decides to not pay attention to that client? Okay.
I was gonna say, like, you might not see, like, if the patient's condition starts to decline, you won't be able to notice that because you're not paying attention to the patient's vitals, to the patient's labs, whatever it is that's giving you, whatever signs and symptoms the patient's giving you, you're not gonna notice and you're not gonna catch on that, so you could obviously let your patient fall through the cracks.
This is from what?
My wife is 42, 38, she's really weak, and now her belly is hurting.
She had the baby a few hours ago. It sounds about right.
No, it's more than that. She wasn't like this with her first child.
It's normal. Just saying. She just
Something's wrong. Now, if you can't come, get someone else.
Thank God it's the only
She's saying her stomach hurts.
Her pressure's a little low, but in the
I know who not to watch a movie.
Brain catheter is not normal. She is in a lot of pain. Go ahead and send her off a CMG. Leah needs a CT. Tell me you are not that guy. What do you mean, what?
That you haven't listened to me or to her husband.
And you are not taking this case as seriously as you should. I treat all of my patients the same. I believe what I see.
Is it a delivery?
I don't care. Get him here now. What is going on? Free fluid everywhere. And she's hypertensive. We gotta get her to full staff. A big vessel must have collapsed because this much bleeding. How long ago was C-section? 6 hours. What the hell happened? Leah Davies wasn't a priority with this.
I wanted to slap
This happens far too often when women have
Oh, so
Bro, if it was one episode that made me cry, it was that one. Okay, yes, Treasure.
Why were they going to the hospital?
Why was who going
What
to?
was the, she was having a baby.
She just had the baby. She just delivered. And remember, now this is way before 24 hours. 24 hours didn't even pass. She started declining. She did have an advocate, which was her husband. And what did the nurse do? Ignore the advocate.
Yes.
Oh, she'll be all right. That's normal. What happened was, if you watch the full video, husband came and looked and said, okay, my wife is in this room, describing the signs and symptoms. She goes in the computer, realizes that, oh, this is a patient of a particular culture, and then she just dismisses the client.
the doctor was just as bad.
And the doctor was just as bad. If it wasn't for the other doctor,
I wanted to
Isn't that the surgeon more?
huh?
Or that's the surgeon?
The surgeon who did the C-section.
But if something's going wrong, that doctor is the one
It was
that has
his,
to be
yeah.
fixing it.
And and that doctor, what's his name? The Indian doctor?
Dr. Bilal.
Brevard, he wasn't even on the case. But y'all could understand. This is why, you see, when you go out there and become that nurse, y'all are advocating on behalf of this client. Please do not be that nurse.
Oh, say it again.
Please, please do not be that nurse that just because a client comes from a particular culture, particular political view, religious stance, whatever, or a particular lifestyle, that ain't your business. We're not taking care of the patient's lifestyle. We're not taking care of the patient's religion. We are not taking care of the patient's cultural background. We are taking care of the patient. And a lot of nurses fail to do that, and it still exists to this day. Emotional landscape, now, you gotta know the psychological changes after birth. Becoming a parent is a big emotional change, and yes, both the birthing parent and the partner, once again, are going through the emotional changes or the emotional roller coasters. So they have the baby blues, okay, which is normal. And what's the baby blues?
Postpartum depression.
Huh?
Well, no, it's like a soft version of postpartum depression.
Yeah.
It's shorter.
It's shorter. It's like, it's a little sadness, okay, because of this baby. Am I ready? There's like still this ambiguity that can take place or whatnot. So you can go from the baby blues, which is normal, all the way down to the end of the spectrum to postpartum depression. Now that's when it becomes a problem. And again, remember we said it is not, the postpartum depression is not limited to just the birthing parent. I need y'all to make sure y'all remember that, okay?
Is that in the book? And
yeah, it's in the book.
Okay. There's really no time period for it.
Ooh, say it louder, please. No, start all over and say it loud, please.
There's no like time, like a maximum time that a person can suffer from postpartum depression.
Mm-hmm.
Don't they have like a postpartum psychosis?
They do have that.
Isn't that where the suicide comes in and stuff like that?
They could. It's not in the book, by the way, the psychosis. But now I'm telling you based off of what my mental health colleagues telling me. They do have a tool where they do screen for that because it's so relevant. Like the person you're referring to, they would have used that tool to see how likely she was to even go that route, and then she would have been on.
But people lie though.
No, they do. That is true because some people know what
for us to say it though. Like that, you're like us being the first line. If we go into the room and we start to see the signs, say something because if not, like you just said, it's not 100%. Like people will fall through the cracks with that.
Yes.
People can lie and be like, "Oh, I'm fine." But if you start to see it, let the professional mental health nurse come and check that out.
And it's really hard to even ascertain because postpartum depression doesn't have a look.
Mm-hmm.
That's where I'm going.
Right.
There's no look. So you can't just look at a person like I see Schmidt with his hand on his, like that. I can't diagnose him by saying he got postpartum depression.
That'd be really cool.
That'd be really, I know, right? Okay? It could just simply be fatigue or the opposite. And, I see somebody's, the mom is all smiley and everything. I won't know to go and screen for that. Now, I saw your hand, Ashley. This is why knowing your patient, having a keen observation of your client is very, very important. Is it always feasible that you're going to be able to do it? Most likely, maybe not because of your workload, so you may not be able to, but as much as you can, observe your clients closely. Because even the slight change in mood can be an indication that, hey, I need to dig into this further. You understand? Yes, Ashley.
But like Danny said, like if family or somebody is helping, that culture also plays a good role in this because a lot of cultures don't believe in that.
Oh, speak to it. Yep.
I've seen it multiple times, especially during pregnancy, like delivery. You got the mom, or like of the mom of the I guess the birth giver or whatever you want to call it.
Mm-hmm.
She's the one speaking for the girl, and you're like, okay, I need her to speak.
Right.
Like, unfortunately, I understand that, but there's certain times where you kind of have to force your patient to speak to you and not the family. Because, like, for example, like she's saying, it happens all too often where you'll have a family member wants to respond to your answer, your questions, and you're like, I appreciate you trying to help, obviously with respect. And that's why the cultural competent care comes into play, because you gotta, let them know it's with respect, but I need my patient to speak to me because I need to see the difference maybe in her answers if there's something wrong.
Education. You can probably try to wait when the patient is alone and you take that time to do your intervention as well. Now, sometimes, it's like we just learned in certain cultures, they may not ever be alone. So you may have to incorporate education, especially if you see a slight change.
Yeah,
okay.
That's like how when we went over that chapter with abuse and stuff like that. Like it may not be abuse in the sense that physically being abused, but some of that it could be like control abuse. So now you have to get your patient to by yourself. Like, hey, we're gonna go run some labs So we're gonna take her down or something, and now you get the family to go away for a minute. You're like, I understand, but we have to do, this is just part of culture.
Yeah.
And now you're gonna go, hey, just need to ask you a couple questions. How's
yes.
everything going? How's that, how do you feel?
In other words, you're gonna have to be slick with it to gather certain data, okay? All right, moving real quickly, Ruben's phase of identity, real quick, you go into the taking in phase, where usually happens within the first 2 days after birth. What happens during the taking in phase, the parent is typically tired, okay? So now they're dependent, or they become dependent on other individuals for assistance, right? They may talk a lot about the birthing experience, but they're going to focus on their own needs, right? Acts may be passive, etc., but this is not the best time to teach about infant care during the taking in phase. Then after that, you got the taking hold phase, and this is all on page starting on 477 for those of you looking, okay? The taking hold phase usually starts around 3 days postpartum, and it can last, according to the book, several weeks. And this is where the parent may want to learn about newborn care, all right? Now they become more independent, right? They want to know how to adequately care for their baby, and they start to ask certain questions, which is normal. And that is when it's the best time to start teaching about newborn care, during the taking hold phase, okay? And then after that, you got the letting go phase, which can occur within months after birth, weeks to months. And this is where now the parent is adjusting to a new lifestyle, all right? All right, that's the main thing with regards to that. Now, again, we already talked about the partner's journey. We got to make sure we assess the partner. If the partner is involved in the care, remember, as we would like them to be, not as required, but as we would like them, or expected in the U.S. is expected, but you may note that the partner themselves, they may go through an emotional roller coaster as well. They might be excited, they might be confused, they might feel scared too, especially if this is their first baby, okay? They might also feel overwhelmed because this might be a lot for them. Some of them are thinking about, okay, how am I going to take care of this baby? Am I mature enough to take care of this baby? Do I have enough financial means? What's my pocket looking like? So they might be stressed too, because they may want to do a good job, but unfortunately there's some barriers that they're contemplating on how to overcome to render quality care for that child. So again, with the partners not involved, it's not many times that they just, a deadbeat person. They're just scared sometimes. Don't be so quick to judge them, all right? What affects the partner's adjustment is transitioning, and assess how involved they are with a childbirth. Again, we're assessing cultural practices and trying to incorporate those cultural practices into the care as long as it's safe, okay? There's no contraindication. The nurses should keep the partner informed as much as feasibly possible. Now, again, remember with regards to, we do have to protect HIPAA. Even though we're keeping the partners informed, the patient is still, the priority patient is going to be your client. Sometimes there are going to be certain things that they may not want the partner to know. So we got to try to respect what they want the partners to know and what they don't want to know. In other words, respect HIPAA. Now, how can the nurses help the partners? Of course, keep them informed, as well as it relates to baby care, swaddling the baby, changing diapers, those things. Include them in the baby care. Encourage that kangaroo skin-to-skin contact, and also invite them to ask questions. That act of them asking questions can help alleviate a lot of tension. And of course, support their involvement as much as possible. All right, and then you see in the center here, there's an engrossment. Engrossment is just basically the partners bonding, okay? When the partners first bond with their baby, that's called engrossment, and it usually have several characteristics. The partner sees the baby as beautiful. They want to touch the baby. They see the baby as perfect. They focus completely on the baby. They feel intense joy. They feel pride or proud, and they also have a sense of maturity as well. That's what happens during engrossment. Partners may bond differently with the birthing parents, but they are fully capable to have a deep attachment, okay? So this is where you want to make sure you're encouraging that the partners hold, they talk, they feed, they cuddle. All of that is for supporting a strong bond between them and that child. Sit down. Okay? Ricky, you and Schmidt, answer this question.
Say that.
Alright.
Read the question out loud.
You got that.
A 29-year-old, third pregnancy, third kid. Postpartum.
Day 9.
After an uncomplicated vaginal delivery, is exclusively breastfeeding. She reports, my bleeding has turned light brown a few days ago.
Light brown.
They suddenly became bright red again. That's bad.
Oh, that's bad. That's horrible.
Emergency.
That's horrible.
Emergency.
That's bad right there. Mild lower abdominal cramping during breastfeeding.
Okay.
Dizziness, no fever, but you got a headache. That's the fundus is firm, midline, and 1 centimeter below the umbilicus. Perineal patch shows bright red bleeding without large clots. Lochia has mild, fleshy odor.
That's normal.
That's
Yeah,
mild.
that's
It's mild though.
What's the question?
It's like what's
Oh, which one of these data is more
you
concerning? Which of these are data is more concerning?
Oh yeah. You see, like this one, you can put on the
Ricci, why did you
exam, just like this. You see how we're thinking
Because
and
Sammy
analyzing.
said if it got like a bad odor, bro, it's not good. Bro.
Fleshy is not a.
That's flesh
Wait,
is
leave him
supposed
alone.
to do
Leave him
fleshy.
alone. Let's
You right.
see. So what's your?
It should smell like iron.
what?
I smell like Ricci.
It should not smell like
It should
fish.
smell like
Fish.
All right,
STI.
Avery, let's go.
Alright, so same thing.
Come on,
It's the
Avery.
same scenario.
The complication, okay, so let's break it down. A is not right. I would think C. That's what I think.
Final answer?
Yeah.
Why?
Because of the bright red bleeding all of a sudden, that's not good. She needs to see her doctor.
Select all.
Oh my gosh, it's small.
Same scenario.
E is the correct statement, but
It doesn't concern the patient.
E is correct. But I have a question because the patient doesn't have a foul odor. I mean, the statement is correct in itself, but it says that the lochia has a mild fleshy odor. Fleshy odor is normal.
Saying foul odor would suggest infection if they did have it.
But you're explaining the patient's
Condition. I see what you're saying.
Because you would mark that wrong on the test.
First of all, the question is which statements correctly explains the patient's condition? And we have to, you have to answer a well-written NGN question. When this is the question, it has to answer according to what's going
Right, so he
on,
was
not
wrong.
what's the supposition. You understand?
so he was
that's
wrong.
why E would have been wrong.
Okay.
Because it's not according to the patient's condition. E shouldn't have even been there. Okay?